performance dashboard. Before I invite exec colleagues to present this item, just to advise the board, I'll firstly come to Claire, just to introduce you to lead the item before handing over to Gethin, who I know will talk through some of the detail of the operational performance section, and then I'll invite other exec leads to present on the quality, people and culture sections as well. Of course, I want this to be a free-flowing conversation. I think if we get through the updates first, and we'll then do questions perhaps at the end of the exec presentation. So I know there's a lot of detail in these reports, and conscious that members of the board will have a number of questions. So what I'll do is at the end of the operational performance section, I'll come to Greg, to Don, to Lauren, and to Philip, probably in that order, unless the chair changes his mind, which I will attempt not to do. Claire, thank you. I'll come to you first. Many thanks.
Thank you. So I'll just outline some of the key messages from the report that I think we've already heard a number of them in both chairs and chief execs reports, and also noting there's many measures in here where there's no marked change or measurement is needed over a longer period than between the last board meeting. So that includes areas of good and poorer performance. So of the 17 of the Sentinel metrics on that quadrant on the first page, we've got 2 that show significant improvement. So nationally reportable incidents over 90 days and weights over 104 weeks. We've already talked about the improvement in elective weights. And 2 show statistically significant deterioration, so the COLA rates and our financial position, but the remainder have no significant change. And then of the quadruple aim standards, of which there are 54, we're currently achieving 20. Picking out from that then the areas of notable practice, clearly the reduction in over 1 hour and under, improvement in under 15-minute handovers. We've not yet seen the same for weights within ED or in the community for response by an ambulance. There's more to do on diagnostics, weight and stroke and hip fracture performance. I think we've already commented on that from the other committees. Positively, we meet 5 out of the 7 mental health indicators. We were disappointed not to receive the expected funding for the neurodiversity waiting list, which is an area we're really improving on, and we risk stalling or falling backwards on. In terms of workforce, we're improving on 3 out of the 4 areas, although there's still clearly work to do. We've got very positive continued performance on long waits, and our financial position is off plan, as we know. So those were objectively the areas I wanted to draw attention to, and I know that colleagues may want to make further comments. So, Chair.
Thank you, Claire. Much appreciated. Gethin, I'll come to you next. Thanks.
Thanks, Chair. So I'll just pick up a couple of sort of key items really that to bring to board's attention. So the first relates to performance for bowel screening, and that has remained low, and not at the whilst we saw some improvement, that has slipped back, and that not only has an impact on those patients who've been referred on the screening pathway, but also has an impact then on our overall cancer performance. So we have a programme of work commencing this month with a specialist insourcing team to clear the backlog. We are now booking at so new screening colons that are coming in. We're now booking at 5 weeks. So having brought that weight right back down, which is really positive. We had a very good meeting with the clinical team with leadership of Public Health Wales yesterday, who were really reassured about our plan, and so focused there on that screening pathway, which I know board members have raised previously. Overall, in terms of referral to treatment times, we ended Q1 with 464 patients over 104 weeks. We were aiming to deliver 450, so we were slightly over by 14 patients at quarter end. that's a testament to the hard work of both the clinical and operational teams to get those patients booked in and to get their treatments prioritised. Of that 464, 460 of those were in orthopaedics. There were 4 patients on a vascular pathway for varicose vein surgery, which caused that with the additional 4. So we remain on track now for this quarter to ensure no patients, aside from orthopaedics, no patients waiting over 104 weeks. The key intervention that we're taking now is the reopening of the elective orthopaedic capacity at Princess of Wales. So as board members will recall, as part of the temporary service change, we'll be retaining the trauma service at Royal Glamorgan, and we will have 3 dedicated theatres for elective orthopaedics at POW, which will increase our capacity for arthroplasty, so hip and knee replacements, which is positive. And with diagnostics, we've been awarded an additional £800,000 to support additional capacity in across our diagnostic pathways, again to support the position with regard to 8 weeks delivery of diagnostics. Clearly, we're considering a contract in an in-committee session of board at the end of the day, but part of the approach around our RTT is the Cabinet Secretary's ministerial priority, which is to reduce the overall waiting list in Wales by 200,000 patients. So we will be working, assuming board approves the contract later, we will be working with a private provider on an insourcing basis. This is a contract that has been procured nationally by Welsh Government for the whole of all the health boards in South Wales, which will, for us, support the treatment of 29,000 outpatients between now and the end of March. So a significant reduction, which will bring our overall outpatient weight down significantly below 52 weeks by year end, which again is really positive for our local populations. That allocation not only includes the outpatient element, but also includes additional funds for the diagnostic element as well, so that we will be able to close many of those pathways for patients. There isn't any additional funds at the moment for the treatment element, but hopefully we can review that one next year. Claire has touched on the mental health performance, which in the main is positive. There's some focused work going on with Part 1A work in adults. A variety of factors have sort of combined to create some delays there, but that is now being addressed by the care group, and they're working through that process. Emergency care, so we clearly talked about the really positive improvement in handovers. Certainly the data the data for this month, so July again is really positive, and some very healthy competition between the sites to win the golden ambulance award. So that's really promising. Our next focus, as Claire alluded to, is on the timely transfer of patients through the emergency department to wards, and as part of that, we are returning the recommencement, or the commencement of the return to POW has now started. So Ward 2 at Royal Glamorgan, which was a POW care of the elderly ward, is transferring back to Ward 6 today, and Ward 20 at POW will transfer into Ward 5. They're wards that have had significant improvements to their environment and have been now set up as a specialist frailty area, with day rooms and another therapy space. So really, a real improvement to the accommodation for our care of the elderly patients at POW. So that will allow us to start to rebalance our, bring our bed capacity back to sort of balance, and then, as I say, will be a focus on the timeliness of patients transferring to the wards. I was just also going to pick up stroke. So we, as was shared at Quality and Safety, we are making there is a raft of improvement work we're making around our stroke delivery, both in terms of sort of the quality of the service, but also in terms of the performance metrics. We are in the spirit of sort of being able to work an inch wide and a mile deep to sort of really embed improvements. We're focusing on two metrics for stroke. The first is the time to scan in 20 minutes to ensure that we get the patients through the scanner in 20 minutes, and also the timeliness of transfer to the acute stroke unit. So that's the first phase focus of the performance. We continued the work with Cardiff. We have the Operational Delivery Board meeting for the first time now in August, which is chaired by Paul Bostock. The Chief Operating Officer in Cardiff will vice chaired by Lauren. But really working through the sort of the commitments we made about having a sustainable stroke service based within Cwmtach Morgannwg, but also Cardiff and Vale, with a comprehensive stroke centre providing thrombectomy. I am pleased that we've appointed a new substantive stroke physician to CTM, which is great, and the consultant stroke physician who had to take a period of time off is on a phased return to work, which again is really positive. And we're waiting the return then of the third consultant from maternity leave, who will be returning back to clinical duties in the autumn. So a number of things happening, which is improving. We recruited an additional ward sister to the stroke unit here at the Royal Glamorgan. So that means we've now got band 7 cover on the stroke unit 7 days a week. So again, really trying to help drive that senior clinical oversight. So I'll leave it there, Chair, and happy to take any further questions on any of the other data.
Thanks, Kevin. Okay, we're going to come to Greg, and then to Dom, and then Lauren, Philip, and then last but by no means least, who's always last on the list, Howell on the workforce section of the report. Thank you, Greg.
Thanks. Just a couple of things from me then. I'm on page 35 of this actual report. So page 161 of the total number of papers. So last week we had a really good run through the PTR, so the Putting Things Right metrics of Quality and Safety Committee. So we'll go into those. Just to acknowledge the work of our patient safety and care group teams in reducing the NRI, so the nationally reported incident backlog. So a year ago we were up at 70. We're down just to 16, and I'm determined to get this down to 0 before I leave in 2 months. And of course, that means that, we are much quicker now in feeding these reports back to, people that are being affected. So good work in that space. Claire mentioned some of the challenges with E. coli. So for new board members, that's a gram-negative bacteria. It normally lives around the gut. The majority, so about 80% of these infections, the source is from the communities, and often nursing or care homes. So we now have, we're still in the midst of rolling it out, IP&C, so Infection Prevention and Control team, that are now working in the communities as well as within the acutes, specifically supporting a number of care homes with catheter-related care. So lots of education and training now going into the community. It's a service that we never had before. So we're hoping to see a reduction in our E. coli numbers coming down over the coming months. Still some work to do across the acute sites with our catheter management. So we're very good at ensuring that we follow the catheter bundle for inserting catheters. We still need some work to do on maintenance of catheter care throughout the time the catheter's in situ. So still some work to do in that space. But I'm confident now with our community service rolling out from a colour perspective, those numbers should start to fall. So that's it from me. Thank you. And I'll hand over to Dom.
Dom to me. Okay, so just two areas that I want to just bring to your attention. So there's the hip fractures, which is page 63 of this particular report. I just want to draw your attention to the fact that the numbers you're looking at here are still the same numbers from April. Therefore, you won't see any change because the way it comes out, it comes in April and September. I have actually seen this week the September data to assure you there is some improvement. The major reason that we are not making vast strides in this is because it's tied to us having an ortho-geriatrician. We have plans for that. It is part of our IMTP. So that will happen over the course of this year, and that we then see, hopefully start seeing our step up improvement in that particular area. But I just want to assure people who looked at that and didn't see any change. That's the reason why. Mortality, again, page 163 of your report. The accrued rate is relatively stable. We're continuing that decrease in ED mortality, which is fantastic news. This week, and this was just fortuitous timing, this wasn't planned, so I could say this before board in any way. We had a meeting with our new partner, Arcus, who have developed a very detailed analysis of our mortality data. Really interesting. What they've done is peer benchmarked us against peers. Arrange the words as you like, so whatever order you want. Whatever I said, you'll get the idea.
All the right, it's not in the right order, isn't it?
Yeah, exactly. Thank you. I've only had a piano. So what they basically does is looked at where we sit compared with, and interestingly, you won't be unsurprised to see we've been compared with a lot of health board trusts in Northern England. Again, looking at our demographic, looking at the fact that we've got multiple different sites, the sort of patients that we get in. Really quite interesting to start getting into that detail of where are we on that. And actually, we're not where you think we would be, right at the very bottom. We are pretty much in the middle table for most elements of that. Still a lot to learn and a lot to move from, but that was quite encouraging. I will bring that into more detail to the next meeting, if that's all right. The thing I do want to sort of talk about, what it's allowed to do for the first time is see where our deaths are actually occurring. So which specialties have we got spikes in? Which areas have we got, particularly when it comes down to operation time? And we can now drill down, get a list of those cases, send it to the team and say, why have you had a spike? I want your report on this. So we're suddenly in a place that we've not been ever before in CTM. It will take us time, we'll just say, to get that rhythm in place, but the mortality board that's overseeing that is going to hold the running all of this. So I'm really reassured we've taken big strides in the last year and a half to get to the stage we are. But I will bring those reports to you in much more detail as we work through. So that's what I wanted to say. And I'm handing over to Lauren.
Thank you. Thanks, Tom. Thank you.
Thank you. So a couple of AHP healthcare science points to flag. Within mental health, you'll see that psychological therapies continues to be a challenge for us in terms of meeting demand. You can see the range of actions that are being taken there by the team. And I'm working closely with the clinical director for psychological therapies to really draw down the bulk of the weights are in our local primary mental health services, and they're doing some testing of the data and the weights there, so we need to understand what's sat in that waiting list. Gethin's given a detailed update on stroke, which was helpful. I think we've also referenced the fact that there was a detailed report that came to Quality Safety Experience Committee last week, so there's lots of focus and visibility in the organisation. There's some updates in the report in terms of a range of actions that are being taken and are coming to fruition around the workforce. So the range of clinical groups working within stroke care, and the team are confident that we'll start to see those filtering through to the metrics. With regard to diagnostics, the slight uptick's been referenced there. It's a tricky time, obviously, decisions that are made nationally around waiting list initiatives, reducing bowel screening, age, and decisions around obstetrics, and how we manage those protocols nationally have an impact on our radiology pathology services. So it's being mindful of those knock-on effects of decisions that are outside of our control. But the teams are working through how we can respond to that increase in demand in a timely way. And then from an HP perspective, we're seeing an ongoing increase in physio demand, but the team have done some checking of the data. So within the RTT data in the report, there's some errors that we'll need to correct. So In fact, the adult services, there's only 48 people waiting over 14 weeks, whereas the report says 84. And in paediatrics, there's only 16 children waiting over 14 weeks, whereas the report says almost 400. So there's been some inclusion of services that aren't reportable into the 14-week wait. So we'll get that corrected. And then also just to flag, because I know board are mindful in terms of our adult weight management service. So the waiting times for that adult weight management service aren't actually reportable anymore, so they're pulled out of this report. But we've still got a really significant demand. So there's nobody waiting over 14 weeks for the level 2 service, but there's a very significant number of people waiting for the level 3 service, because we've just not got the capacity and the team to meet the demands. That's currently sitting at nearly 3,000.
3,000. Thanks. Everyone, Philip.
Great, thank you. Moving on, echoing Dom in terms of some of this data has stayed the same from the last session simply because of the pegging of when data is used for public health. But smoking cessation against the national target of 5% of smoking population attempting a quit attempt through smoking services, we've got 6%. You'll notice as well over the last 4 years that has actually increased by 50% in terms of where we were. So that's good. We've still got resistance to all barriers in terms of carbon monoxide testing and validation. A lot of this is being done remotely, and people are actually quite resistant to being tested and see if they're telling the truth, to be honest. So that's an issue nationally. In terms of substance misuse, we're going up to recommission Tier 1 and Tier 2 substance use services at the end of August through the Area Planning Board. And we've had interest from providers on that, so we will see some changes there. In terms of age 5 vaccinations, we've got the highest in Wales at 90%, 90.3%. It's not where we want it to be. We want it to be at least above 90.5%, but it's a challenge that's happening across Wales in terms of the vaccination. I mean, especially for those of you living across the border, the MMR, so especially in terms of measles, so measles, mumps and rubella, the MMR1, which is the jab at 2 years, we're running at 94.8%, and the MMR2 we're running at 92.2%. So if you're looking through other areas of the UK, we're doing it very, very well, which is fantastic, especially given the outbreaks that are happening currently. There is a lot of work, obviously, in terms of children's catch-up campaigns, equity, taking the service to people where we see there's low uptake, but there's a lot of work in place. Likewise, with human papillomavirus, HPV vaccination, we're the second highest in Wales after Swansea Bay. We'd like to be above where we are. But we're targeting schools with low uptake. There's a range of interventions underway. Vaccination for influenza for adults over 65 years. We are fourth in Wales. We're mid-table. It's certainly not where we want to be. We're at 69.3%. Wales is at 70.4%. We're not lagging far behind, but clearly there's still a lot of work to be done. There is a lot of activity in place. Just to put that in context, we're now exceeding the level we were at pre-COVID. And clearly there was an increase during COVID, and then there was a massive decrease post-COVID across all health boards in Wales. We're back to where we were. The vaccine delivery plan is in place with an equity plan. There is lots of work working with comms, for example, tackling vaccine fatigue and misinformation. We've agreed for that vaccination bus to take the service out to underserved populations, which is fantastic. Delivery will be a mixed model, majority through GP, supported by community pharmacy as well as community vaccination centres. And the health protection operational team, which is now in place, will be supporting home-based patients for 10 GP practices, and the additional flu vaccine sessions will be held in community vaccination centres from early December. So we're starting our vaccination campaign early this year with the hope of catching as many people as possible. It's not on the report, but obviously there's a raft of other activities, for example, around staff vaccinations as well. COVID is being decoupled from the flu, but there will be occupational health delivery in the three district general hospitals, peer vaccination on wards and acute sites, with backup from the health protection operational team in terms of community vaccination centres, community sites, etc. And we will obviously be paying special attention to clinically vulnerable populations where there is very low uptake across Wales. These people who are eligible for it but may not feel that they need to pick it up, but obviously they're often the ones that end up in our ED. So that's in the chairs.
Thank you, Philip. Howell, I'll come to you next. Many thanks.
Well, thank you. So first thing just to mention, I think you remember from the people plan item at board in May that we talked about producing a slightly different set of people metrics to take account of some of the leading indicators. You know, when you measure things like sickness, turnover, those things are after the event and they're often too late. That said, they're really important indicators as to the health of a workforce. So we are working through that at the moment. We hope to bring something to board in the autumn to show some of that dashboard that we'll be using to monitor where we are against some of our people plan ambitions. However, the data in front of you I'll go through now. There are some new data points in this month around comparators with other health boards. I will go through those because they are for different months. So it's not terribly helpful, but I'll talk to those as I go through. Turnover remains a fairly positive picture. So our turnover for all staff groups is now around about the 8% mark, down from a high of almost 13% about a year, 18 months ago. Significant improvements in both nursing and medical turnover. Our most significant group for turnover at the moment remains HCAs. You know, HCA salaries we know are challenging in comparison to other sectors, and very mobile in terms of that group. So we are doing some targeted work there, and obviously there is some work ongoing nationally in relation to that particular issue. But turnover generally is really positive for us compared to where we were. As far as then pay bill is concerned, so you know, the agency as a proportion of the pay bill is reported there. Again, in the graph there, we don't compare very well at 5% for March. However, the average for the first 2 months of 2025-26 is 3.9%, so that has come down. Some of that will be to do with issues around pricing and other things. However, it has come down as a proportion of our pay bill. In relation to PDR then, I think I've noted at several boards now that we've got stubbornly slow but steady progress. So we've come up from a sort of low of 50% on PDRs back in, again, 2021 post-pandemic, ticked up to, very stubbornly below 70% for the last couple of months. Again, don't compare brilliantly there. We just now have to give that extra push, I think, to get us to where we need to be. You will also note that I've talked to you previously about the fact that we redesigned our PDR process. That has been really well received by staff. We also had that audited recently and it came out as reasonable assurance. But as you'd expect, the auditors commented on us just needing to kick on and get towards our target and have better arrangements for performance managing that. So we will do that. Stataman training, there is no comparator graph for that one shown, but we are, again, just below target on that. So 85% target, we're at 81. However, in the table there are some notable areas which are really important areas, particularly around fire training, resus, IPC, for example, that need a push to get them to where they need to be. So much the same as PDR, really. We just need to give it a final push, if you like, to get us to where we need to be and then exceed target and keep that going. So I'll pick that up as a conversation with corporate departments and operational colleagues to see what we can do on that front. Our real issue, I think, in terms of being a real outlier, I think, is around sickness. So our sickness rate in month is 6.4%. That is below the comparator rate of 6.89. Sickness in Wales is much higher than in NHS England. So you can see from the status graph on page 154 that's been provided, the comparator data, that 6 of the 7 health boards are above 6%. average sickness across NHS England is 5.3, and in the north of England, the northwest in particular, which is often seen as a bit more of an accurate comparator, it's about 6.1. So we are probably about 1% off where I think we would normally be, and pre-pandemic levels, we were around about that level. However, even then, we were the highest among our peers. And again, I think one of our at that time when I arrived here, one of our explanations for that used to be about deprivation. I'm not fully convinced by that argument, if I'm honest, because obviously there will be aspects of our workforce that fall into deprived categories. However, I think there is far more for us to do. What I would say as well, though, is sickness management is not just a widget game, so we can't just manage our way out of it. There will be things that cause it that are dynamic, and we need to lean into that, which is what the people plan is all about. So hopefully if we bring together the actions from the people plan and the staff survey together with what I think we do need to do around managing sickness more effectively, which I think has slipped post-pandemic for reasons that I understand. We've been through a very difficult couple of years. I think we can probably get to a better position on that. My team are in the middle of doing a deep dive on that at the moment. We've got some areas that we are targeting in particular, including maternity and estates, but I'll continue to keep you posted and update you as that work progresses. That's probably all I wanted to say, Chair. Thank you.
Thank you, Al. That's very much appreciated. And my thanks to the exec team for a very comprehensive update. Before I ask colleagues if they have any questions, question I think probably for Gethin and maybe for Claire, just in respect of the ambulance performance data. We've alluded to the fact in this meeting today that we've seen a really significant improvement across our sites in terms of the speed at which patients are now handed over from the ambulance to the ED. We know that's resulted in an improvement in the number of lost ambulance hours. So if we're looking at the data, I accept there's a lag in reporting. If we look at our handover. So notification to handover within 15 minutes. April came down to May has now come down to June. If we sustain that improved performance over the next few months, bearing in mind across those 3 months, the ambulance response to red calls has basically stayed stubbornly high at just below 50%. Sorry, stubbornly high. It's been stubborn at just below 50%, needs to be higher, of course. We are not seeing, in respect of the ambulance performance, an improvement in their ability to respond to red calls. I think there are some issues here for the board to consider. Now, if over the next few months, our performance in terms of handover, our performance in terms of recovering or certainly preventing lost hours, if that is sustained, then people will rightly ask the question, why is it that our ambulances are not arriving far more quickly to collect patients when there is a 999 call? Now, some months ago, it was probably well over a year ago now, Gethin, we had a development session, didn't we, with Stephen Harry when he was the Ambulance Services Commissioner. We looked at a whole variety of challenges around the ambulance service, around our geography, the nature of the vehicles they use, etc., etc. However, there is a belief that poor performance at ED is by far the biggest single contributing factor to a poor performance by ambulances turning up quickly enough to pick up the sick and the dying. The data will start to call that into question. We know we've been criticised as a health board by the coroner's court for ambulances not leaving hospital quickly enough to collect people when they're ill. Now, if our performance continues to be sustained and to improve, then board will rightly want to know why our ambulances are not collecting people and bringing them to hospital and seeing that performance improve. So I do think, I don't want to throw up a huge debate on this, or maybe I've just started with that. But I do think maybe some time in either a board briefing session or board development session for us to return to that really thorny issue as to why it is, if ambulances are not on our forecourt, where are they? And people will rightly, I think, start to ask that question. So it may well be that we need to do something jointly with Welsh Ambulance Services Trust or with colleagues from the JCC but I think it's time that we return to this.
Yeah, no, I concur, Chair. I'm just looking at the weekly JCC data now, and the for RCT and Merthyr, the response time has remained fairly static. There is an improvement in response times within the Bridgend locality. I think when Stephen Harry came and presented some time ago, a number of issues were flagged regarding the timeliness of response for with regard to the placement of ambulances within the CTM patch. CTM's probably got some of the lowest numbers of advanced paramedic practitioners, and so forth. Equally, I think it's important to recognise the work that the Navigation Hub is doing in terms of mission avoidance. We're working very closely with Welsh Government and the Six Skulls team around a programme of work for which I cannot remember the new title, so forgive me, but as what I would describe as a ticket to ride model for patients in nursing homes and residential homes, where the Navigation Hub will review the patient prior to a decision to convey, because we know the patients that experience the longest waits on our forecourts, the patients that historically face the longest waits in our EDs, are those that are often those that are the most frail, because the reason for admission is not a clinical one. It is often a more social aspect, and so it's important, I think, we look at that in the round. So I would welcome a JCC conversation regarding that.
Thank you.
I'll pick that up.
Patsy, thank you.
Just carrying on that theme, really, I did want to say really well done on the 100% red release, which again should contribute to the ambulance performance. But as chair of audit committee, I am continually asking JCC to focus on their highest risk on their red risk register, being a risk-led meeting, and it is very difficult to get them to do that. I would say they probably spend about 10% of the time of the audit committee discussing that, regardless of my continual request to focus on that issue, which is the highest risk on their own risk register. So that's a further frustration, let's say. I did have a couple of other questions, apart from saying well done on the red release. On clinical coding, we had a year of exceeding the targets, and now we're going down. And I can see it says it talks about the impact of the disruption of POW and the roof. It talks about demand. I wouldn't have thought demand would change. I understand that the flow changes, but I don't quite understand. It didn't really tell me what's going to help it improve and get us back up to reaching the target. And my other point is around the target on NRI's, national reportable incidents. We're talking in this report about the timing to respond to that, but surely the emphasis has to be on preventing those things. I know we've got all of the LFERs and sort of the learning from events, but if you read this report in isolation, it only talks about the timing, doesn't really talk about the learning and the prevention. And so I know it's national, I know, that the timing we have to put in there, but I just think we need to look at the emphasis, really. Yes.
Thanks, Patsy. Stu, do you
Yeah, should I pick up the coding one? Thanks, Patsy. So no, you're right. In terms of, so when we did the WPAS disaggregation work and the realignment, there is a significant amount of data quality issues that we've identified, that some of which we were anticipating. I think there's more than we expected. I think I would try to refer to that earlier in the week in ODC. So we're seeing an increase in the amount of coding activity as a result of some of those patients coming across. I do think it'll resolve itself over time, because the team's actually spending extensive amounts of time at the minute going through these records, making sure that they're actually coming across correctly, because it plays into, we had a bit of a delay in being able to provide our RTT data as well as a result through June. So yeah, it's just probably a transitional thing at the moment. I don't think it'll carry on that way
But this data takes us to April before the
Yeah.
first integration.
Yeah.
So
Well, there was work
that-
done prior to that as well. Yeah.
Thanks, Patsy. Okay, Kath.
Yeah, thank you. Yeah, I've had a lot of my questions answered, so thank you. I think it's been really useful. There's a couple of things I just wanted to raise. I think one was around the mental health assessments, and whilst there's been some improvement, we're still not anywhere near our target. And it's also, I guess, my question is, which I know it isn't picked up here, but is around the quality of those mental health assessments as well. Because that obviously has a massive impact. And I know we're looking at a mental health transformation programme, and encourage Geraint to hear it, that the team are now looking at this in more detail, because I think there's some national aspirations around mental health and really timely intervention that we really need to focus on moving forward. And I think the second thing for me was the ADHD assessments. I know from visits that there is some frustration from some of our partners where they feel that perhaps they could assist in some assessments. And they've been trained, but apparently we're not allowing that. Now, I don't know what the detail is, but I guess it just opens up that whole conversation around, if there isn't more money that we can just throw at this, which we know how tight the finances are there other people who can help us bring some of these waiting lists down, particularly around the ADHD assessments, which also ties into those. I know it's difficult across CTM because, Bridgend, RCT, Merthyr, we can't just have one hub like perhaps an urban centre can. But how are we really going to bring some of these waiting lists down and really support people who have been waiting a really long time around, for some of these assessments more generally, I suppose. So I don't know.
John?
Yeah, the ADHD one is a tricky one, and obviously it's split between paediatrics and adults.
Yeah.
And there's a huge demand in adults for some, but we have no plan or funding in that area other than what we've currently got. The paediatric one is expanding even more. The team is at capacity and trying to do more. There are alternatives out there. Problem we've met a few times, and it's coming when more private providers rather than third sector. Is that there's then an expectation that the GPs will then pick up the prescription on it afterwards, and GPs saying, well, hang on, this has come from a private, we're not funded for this doesn't fit in the rest of the service. So we haven't found the right way, but there are a number of third sector organisations that we can look into to do that, and the CAMS team are aware of that. But I will pick up and follow up with that.
Thank you.
Thanks. Catherine?
Yeah, so I guess just coming back firstly on the mental health assessment. So aside from the last couple of months in adults, our performance has been really consistent in terms of timeliness of assessment in mental health. So I think it is, we have seen a dip over the last 2 months. That's predicated by sickness in the medical team and some challenges around the administrative process, which is part of that transformation program you alluded to, Kat. But I've got assurance that we have a plan that will bring those assessment times back up. But I think I guess I'm a bit concerned about your comment about non-delivery, because actually we have been one of the best performing health boards in mental health assessments aside from CAMS, which we've addressed. So perhaps we can pick that up outside of board. In terms of the ND piece, the issue you raised then about us not being willing to support others to do the assessments, if you can share the detail with me, I'll happily pick that up. I guess I know that we are doing some really innovative work with primary care clusters on this, so very much. But of course, as with any clinical assessment, there is a real level of criteria that we need to be following, and it has to be done by people who are qualified to do those assessments. We're looking at we had a conversation yesterday with an organisation that's doing some other work elsewhere in the UK, and to understand what we can learn from them around digitising some of that. But again, our allocation for ND has been cut this year because actually our performance is better than most other health boards. So I think it is that representation, isn't it, to the centre, which is actually, if you give us money to address it, we address it and address it well and sustainably. But as I say, if you can give me the detail of those examples where we've not where we've said we can't support, then we'll pick those up.
Yeah, thank you. Thanks, Kevin. Yeah, right.
Thanks, Kath. Hayley.
Just a couple of things. First one was vaccines, staff vaccines. We know it's really important that we've got to try and get as many staff vaccinated, isn't it? Do we usually struggle to get?
Yes, and increasingly so.
Yeah, and I wonder whether it's more of an ops thing rather than a strategic thing, really, with sort of access. With
That's sort of big hole then as well.
Yeah, happy to come in as well, because I think bit of a double act with myself and Philip this year in terms of the staff vaccination plan. We are looking at some slightly different approaches.
Yeah.
This vaccination season coming,
Last
if
year
you
was
like.
quite difficult.
Yes, indeed. So we're just doing some work on that at the moment between our two teams, working with colleagues across the health board, really. So we'll come back to you on that. It is a bit different this year in terms of where we are with COVID and what the requirements are, which will make it a slightly different season to last season. But yeah, some work on that at the moment. Yeah.
From sort of like staff voice.
Yes.
The roving teams, I think, are the preferred methods, just because they can kind of come in and go, wicked, I've got 10 minutes in between patients, go for it. And it's not the fact that people don't want to be vaccinated, it's just that release time to then go and travel to your...
Agreed. I think we recognise asking people to schlep off somewhere else just doesn't work. Yeah.
Okay. And then the second one was PADRs. I think no, and it's probably clear from when we go into sort of care group level that some care groups obviously finding it a lot easier to hit that than others. And I wonder whether some of that difficulty is more on sort of maybe sort of staffing and that job planning and sort of allocated spa time. Because we know the clinical work will always trump CPD. That's the first thing to get fresh from your diary, isn't it? And whether we sort of try to really protect that time, especially for this type of stuff.
Yeah, so again, I think we need to think of innovative ways to do that. I'm smiling slightly because you just described SPA time as spa time.
Yeah, that was why I was smiling as well. I'll do that, please.
Yeah, sorry.
My face is what different.
But yeah, we need to find innovative ways to do that. So yeah, it'd be a good one for us to perhaps pick up separately about any ideas on it.
And just to say on the staff vaccination as well, I mean, we were focusing on the winter vaccinations, but clearly MMR is vitally important. And there's two issues. What one is whether people have been vaccinated in the first place. The second is whether line managers know whether their staff have been vaccinated. So if we have an outbreak of measles, for example, we know about the vaccination, contact tracing.
And it's definitely that kind of previous history of, I think I've had MMR twice. I've had 2 lots of MMR because people just don't believe me that I've had it. So they'll just give it to me again.
Yeah, and there's no harm in
I
it.
don't
There's no harm in it. So,
Okay.
Any other questions to the exec team on the performance report? That's right. Okay. Thank you all very much. Okay, we're going to move on to the second part of delivering our plan, which is the month 3 finance update. And if I can hand over to Sally to present the report, which is for the board for noting. Thank you.
Thank you. There are just a few things that I need to draw people's attention to, which I'll do quite briefly, and then also to some correspondence from Welsh Government in response to our month 3 monitoring return. And just for background for people who are newer to this, we work to a very strict rhythm in finance. So day 5, we report to Welsh Government at a high level about monthly performance. Day 9, working day 9, we report in the monitoring return format, and then they write to me every month, sort of pointing out any issues or errors, but also giving sort of high level messages around what we're reporting. So in terms of the report, I'm going to sort of head towards the back in terms of things I just want you to sort of clock really. So in terms of the income assumptions, we've currently got an assumption around £94.2 million of anticipated allocations not yet confirmed within this month 3 position. Subsequent to reporting at day 5, there have been some of these that have now been confirmed, but in a way that is adverse to our assumed allocation. So the pay award funding for 24-25, which we've been awaiting the recurrent impact of for some time, is some 1.6 million lower than this assumed funding. The employer's NI funding, there is insufficient funding provided via the Barnett formula, and across Wales, some 16 million is being passed out to health boards and organisations to mitigate themselves. For us, that's the equivalent of around £2 million. That's a non-recurrent position, and it would, we think, approximately double next year to 4, because they funded half of it from Central Treasury, Welsh Treasury reserves this year. So that is an issue. And then next down in terms of order of significance is the POW roof assumptions. That's the additional costs incurred from running both planned care and in particular the Vanguard units based here at the Royal Glamorgan, and other costs associated with that. I've now been asked to write separately on that, as we did last year, and we're just finalising and reviewing some of the actual costs, particularly in relation to the Vanguard and things like energy costs, that we just want to be able to provide some actuals around. So clearly, that's at a point in time, 94.2 million of anticipated funding. There are some issues that we'll now be asked to mitigate, and that adds to our financial challenge in year. So it's outside of the assumptions. And then if we move on to the savings, so we are continuing at month 3 to report a forecast break even, but our savings position at this point is falling short of our 31.3 million target. So the forecast in-year savings is currently at 17.9 million, which is 13.4 million below our 31.3 million target. And that's obviously assumed that we'd get all those funding bits that I've referred to above. And then the table that you can find at page 19 sets out all the risks and opportunities that we're continuing to have to manage through this process. Some of those will now crystallise because it's about the outstanding Welsh Government allocations, but there are others that are still working through, the most significant of which is a likely increase in the amount that we need to pay out for the Welsh risk pool in terms of settlements coming forward as part of our risk share. The estimate at this point is £42 million across the NHS Wales, of which our share is, with that, if it materialises at that level, would be another 6.5 million. That is outside of our planning assumptions. And there are some other elements that are also hitting us. So those are the bits that I just wanted to draw your attention to. Give me, if I just try and find the actual letter, because I think that will help me work it through. So as I say, each month we're written to by Welsh Government officials in response to our monitoring return submissions. And this time we've had a response that is recognising that we're reporting a year-to-date position of a deficit of 4.783 million and a gap in our finalised savings plans, which we just described. So what they're asking us to do, and what they've also said, I think it says, I trust you will inform your executives and board presently around this. We need to agree urgent actions to achieve a requirement of, by the month 5 return, which is on the 11th of September, we need to be able to finalise and address that savings gap and have turned all the schemes green, for which there are clear criteria. And so we're being asked to consider, and we've started to do that in terms of having meetings with care groups and started to look at our position about how we agree actions to achieve our savings schemes. And it says here, significant progress will be expected by month 4 submission, and supporting narrative must clearly state the actions that have been agreed, and a further statement on the attainment of this deadline will be required as month 5. So there is a larger focus on us demonstrating that we're delivering our savings plans. And I just really needed to bring that to your attention, given the letter that I've received.
And Sally, as part of that dialogue, if I can call it a dialogue, with Welsh Government. Are we being very clear with them that having started this financial year with a set of very robust assumptions and a plan which they approved, there are now things that we are having also to respond to by way of financial risk, not least the increase in the cost of the contribution to the Welsh risk pool and the £2 million gap or so in respect of the national insurance contributions that have not been funded by Welsh Government.
They are clearly cited on all of those things, and there's the dialogue. I suppose our position should really be that at this point we need to deliver the plan that we said. So that delivering the savings and then considering how we address the mitigations of those additional issues outside of that is probably a separate set of conversations. But whilst we're still not delivering on that savings requirement, our position is not as strong as it might be in terms of some of that other debate.
Thanks. Questions for Sally on the monthly report?
Sorry, yeah, I was going to ask about the savings anyway. So you know, in terms of timescales, so I'm not quite sure what the answer is because it's evolving, isn't it, throughout the year, I guess, in terms of detailed savings plan. Sorry, Sally, it's a bit of a detailed one, but on the cash flow, do we have a minimum cash flow in year that we have to achieve? Because I'm just noting some of the cash flow goes down to 680 or 681, and I know by the end of the year we want to achieve 0. Is the cash flow showing? But is there any risk in going down? You know, how low can we go on our cash flow?
Well, clearly we always want to have sufficient cash. We don't draw down cash ahead of need. So our normal thing is to have a balance that goes no higher than 6 million. But it will fluctuate during the year and by day, because obviously it depends on whether you settle some of the larger bills. In previous years, if you're in a deficit position, it has been necessary to draw down or request strategic cash support, which is what we did in 22-23, where we had a £24 million deficit. But we'll manage that very carefully. I think last year, health boards who were in deficit were not provided with the full extent of their strategic cash support requests. And you know, it very much depends, doesn't it, on what Welsh Government is able to cover in that regard as well. So we will keep it very carefully monitored throughout the year. But yes, if we deliver our plan, it puts us in a better position for that.
Sally, just again, just reflecting back to what we set out in that plan and some of those challenges around delivering those efficiencies, the response from Welsh Government that we've now had about giving that further confidence and clarity around delivery of the plan, is that conversation, does that feel different to the conversations we had last year? Because clearly each month as we go through the financial year, we look at our efficiencies, we look at what's been saved, you know, we report against that. And obviously I know that is part of the conversation that you regularly have with Welsh Government officials and we have with Cabinet Secretary, etc. But the type of conversation you've had, does that feel different to what's happened previously?
Not really. I suppose at the moment, each year we have a sort of a set of reports you'll see across Wales, which shows the extent of the potential deficit issue. And a way through has been found in previous years. But at some point, the flexibility within Welsh Government positions, and I think the Cabinet Secretary has been clear that unlike in 23-24, he will not be going back to his fellow Cabinet Secretaries to ask for resources to be diverted into health. I think the forecast across Wales is currently significantly in excess, or a straight lining of the current position would take you in significantly in excess of what they've planned for, and that is a real issue.
And the projected collective deficit for NHS Wales on that straight line is in excess of 100 million at the moment, isn't it? For the whole of Wales. And we do know in England that there have been some very, very well, more than just strong messages, but decisions by the centre that there will not be deficit cover in England. So yeah, we have benefited from a level of flexibility in Wales that is now starting to disappear, I suspect.
And what we can also see is that over time, our head count has increased.
Yes.
And the focus in England has been very much about head count reduction or holding the head count. And that has included in clinical services. So in many ways, it is, we need to be able to manage our finances so that we don't suffer those sorts of shocks or those sorts of difficulties, which are far more difficult to step back from than just trying to manage where you are now.
If we need to schedule further time in a board briefing or development session, just to come back to all of the work that you're doing, the work that Howard is leading on as well, in terms of some of those, that savings target, then more than happy for us to do that. I think it's really important the board is remains cited, and I know you provide a huge amount of detail to us, which I really appreciate. So again, I know it's a changing situation, but if you need more time from the board to do that, I'm more than happy to.
Okay, appreciate that.
Thank you very much. Thanks. Okay, unless there are any further questions to Sally, we'll move on to item 6.3, which is the Primary Care and Community Transformation Board work. I know that Gethin and Sarah will be leading on this. Sarah, I did mention, now feels like a long time ago, as it was an early start this morning, but I did explain that you were attending the board today to help present this item. I know we've got some slides for presentation as well, but huge pieces of work now being done around our primary community care, which sit alongside all of that additional work we're doing around the hospital at home scheme, enhanced community care, really looking to revitalise what we do outside the hospital environment. So over to you. Thank you very much.
Okay, thank you. I've asked Emma to drive the slides as Gethin and Stuart know, not my forte.
No problem.
So okay, so this is, I won't go through the summary, and there's quite a number of slides in there, so I'll just draw attention to the key ones if that's okay. So just moving on to the first one. This just gives you an overview of the activities of the Primary Care Transformation Board as it stands to date. We are really fortunate. We've had Paul Mears, who is chairing that transformation board, and we've got the support from the National Association of Primary Care, who are experts in driving forward new models of care within healthcare setting, mainly in England, but they are now starting to come further into Wales. They were first with us, but they are being engaged by other health boards. So this just gives a summary, but I will cover some of these areas in the rest of the slides, if that's okay. If next slide, thanks, Emma. So the first thing that we did when we embarked on the transformation is that we mapped and did a service mapping for all of our services. We started with GP practices. GP practices are the hubs of our community. That is where they are mainly the care coordinators of care. So we started this point in time. We've got 44 practices. This map just shows you 44 main surgery sites, and there's 29 branch surgery sites. What it's showing you though is those practice locations are actually distributed along the main communities, our community networks. They are follow the main valleys lines of our natural communities. So moving on, please. As we mentioned, we also did a wider mapping work then with our wider healthcare services, like community nursing, we're doing secondary care, specialist community nursing services, local authority and so forth. On the right-hand side, it just shows you the level of service, the level in which the services operate. As you go down to levels 1, 2, 3 and 4, you add the complexity in of patient care. So moving on to the next slide. So this is an illustration of our current services, which, as you can see, is a minefield. There are individual separate teams that are mapped, and they all provide services and all provide support into our GP practices. It is very difficult for that GP practice to navigate, let alone our other professionals out there who are supporting patients, and let alone our own patients. So if we can move on to the next slide. The reality is this complex web doesn't actually give anybody a really positive experience. And we've got multiple teams. You've got patients who are telling their story to multi-professionals. They're repeating themselves time and time again. We've also got a fragmentation of the services. They don't all talk to one another. So within those services, we've got a handoff at times, and we've got self-referrals into those teams. And the fear is we've got patients who are probably falling through the gaps, which we need to resolve. The other aspect that we've gleaned out of this information, it is known already, is that we don't have a one single patient record. All of those services have a single record in which they record their information. Some of them don't even have a clinical system. They might have just a rostering system rather than a clinical system. So what will come out in the next couple of slides is that's one of the focuses we want to pull out is a digital work stream. If we move on to the next slide, and again, it's not only the variety of individual teams that we have also disparity across our relevant local authority areas or locality areas. So in Rhondda, Cynon, Taf and Merthyr, we've got the model which is on the left-hand side, and we've got separate specialist teams, community nursing, wellbeing services, local authority, and then a range of other specialist services supporting patients who are escalating in their care. But within the Bridgend area locality, which is on your right-hand side, we have an integrated network team. On paper, it's brilliant, but there are nuances within that team around there are improvements that could be made. So there's pros and cons of both models. An integrated team is where is our ambition, and it's where we want to end up. But we're not leaving out Bridgend. We're looking at Bridgend as well as looking at RCT and Merthyr, even though there's slightly different models of care. So we can move on to the next one. So we've also mapped our district nursing services. No surprise, our district nursing services absolutely align with our GP practices, all in the natural communities that we have. We are quite unique in CTM. So we have district nursing teams who are practice-based, and unlike other areas, they could be based on a centralised basis. So we're starting from a good footprint. Okay, and this is our community pharmacies. So the interplay between GP practices and pharmacies is really crucial. They provide a range of services and they're complementary, but they are mutually dependent on one another. Again, they map around those natural communities. We got 109 pharmacies, not necessarily 109 contracts, but we have 109 community pharmacies across the patch, providing a range of services. We move on to the next one. So in order to take the work forward, it's not about a top-down approach. It's not about the health board telling our multi-professionals what they're going to do. We've actually appointed 3 GP leads who have taken a lead from a transformational point of view. We've based it on a locality basis rather than a cluster basis around the natural communities that we have. So we've got, isn't it? I'm going to start with Rebecca Broughton, who's supporting.
We've just taken their names out of the slides.
Did you?
No, but I noticed it just says doctor.
They used to be in.
They were in there, yeah.
From Ross House Surgery and covering the Cynon and Merthyr, we actually have Jen Lewis-Jones, and we have got Jeff Smith. How can I forget Jeff Smith? We got Jeff Smith, who's covering the 3 cluster areas within the locality. And I have to say, they have entered into this with the spirit that we wanted, haven't they? They are very, very enthusiastic, and they're biting at the bit to lead this transformation work. So they each 2 sessions a week on a Wednesday, which is the busiest day for the health board, but hey ho, we're trying to make it work. And each of them are providing support to this programme. Their key roles will be strengthening that communication and that engagement with our GP contractors, but also the wider teams, especially our nursing teams. That is critical in the work that we're taking forward. But they will also provide us with that advice on how we should engage with our multi-professionals, and also how we should engage with the public as well. But they are going to give that specific focus to us around the key areas of change. So there are some quick wins. They've already identified some areas that are the main I'm going to use the main focus of their attention. That's being fed into Dom and his work stream. And there's a close alignment with the work that Dom's leading on with the engagement with GPs and the primary care transformation programme. One thing I forgot to mention at the beginning, that we've got a primary care transformation programme, and I at times come to this group to talk about the wider transformation for enhanced community care. We've got palliative care and end of life transformation, and we've also got the dental contract and changes. All of that work feeds into this overall primary care transformation, which will have the oversight on those individual programmes. If we can move the slide on, please. Okay, just to go through the roadmap. The work that we've undertaken to date, and this large amount of the work, or most of it, was undertaken by the National Association of Primary Care, was to listen to people and listen to the stakeholders. So there were 80 stakeholders engaged. I won't go through all of these themes, but these are the main themes, 8 of them, that were identified and have been the starting point for the focus of our work. We move on. Thanks, Emma. And then again, we are setting up work streams to take the work forward for 25-26, but the work streams are being driven by these focus areas. We've divided it down into leadership, governance, transformation, the primary care model, the accelerated implementation, culture and the people development, and the medium financial strategy. But moving on again. So this is the important slide, and this shows the various work streams and how they're going to progress over the year. So I just want to draw attention to the first one, which is leadership and governance. So we've already put that structure in place. I've talked about the GP leads and the board taking the work forward. But the other thing I need to emphasise is this one, which is around the communication and engagement. And that goes across and continues across. It will never finish, because that is the key to making this programme of work successful. And the other programme I draw attention to, which I mentioned earlier, is the digital and data and information. Because unless we get that right, we're not going to fulfil our desire of supporting the patient, or we won't be able to measure the outcomes that we're hoping to achieve. So I won't dwell on that any further, if that's okay. And if we can move on from that one. So just the next steps. The next steps are we need to agree and set principles for focus for the ambition. But first and foremost, we need to set the vision and describe that vision, both in a narrative, but also in an infographic, so people can understand what we're going to try and achieve. We continue to build the picture on the service mapping and include that practice workforce that's out there within GP practices, then going on to our community pharmacies. We're also building that picture of the financial breakdown, because if we don't have a baseline, we can't measure the scale of the investment and the transfer or the shift of resources that come out of secondary care into primary and community. Yeah, the clinical leads need to share the details of their work programme. So it's not just about them working with us, but they need to actually work with the clusters and the cluster representatives on their own, and they need to drive that work forward. It's not all about the health board, but we will obviously work with them. And we then need to start that concept around the wider work around our integration with social care. In the first instance, we really need to get the health services organised in the right place and working together so that they're ready then for that wider integration with social care. I will emphasise that actually what the information is showing us is that we need to develop teams that are based on natural communities, wrapped around the practices, wrapped around the patient. So that was just a listen to us.
Thank you, Sarah. Before I see if the board have any questions, Gethin, thank you.
Yeah, thanks, Sarah, and thanks, Sarah. Just as I guess to set this in that strategic context, we recognise that effective primary care is the absolute bedrock on which we build all our clinical services. So we cannot deliver resilient medical services to our population if we don't make general practice that absolute bedrock, community that absolute bedrock. And I use the word primary care distinctly to general practice because it isn't just about GPs. It is about that MDT and that team. And you know, one of the pieces that has really progressed in the conversations that we've been having and the engagement of our GP leads has been really helpful in this. Is really shifting us to think about how do we use the construct of the natural community as that first piece, and that might be a single practice, it might be a cluster of practices, it might be a broader cluster, but what we don't want to do is there is a one size fits all which every team needs to be 15,000 people and it has to be about creating teams that are about that natural community where there is that natural flow. As we've discussed at board and in board briefings, you know, a range of our services are not currently aligned to work in that way, and a big part of this is understanding how do we move our services into something that can integrate with general practice. And it's not just about us doing stuff, it is also about general practice changing how it operates, and how it operates both in individual practices but also at some of that scale. I use the analogy of making sure that we've got, you know, we're all working to the same plug and socket plan, because I always have this vision that we'll end up with a European plug and a British socket, and if we don't map that through, and you know, so this is really important. So you know about the ECC work, so that's about taking all of those services that we need to run on scale, doing that once, but bringing them into a single team. Because at the moment we've got a myriad of teams doing some of that stuff. We've got a range of specifications, some of them so it creates overlap in some and creates gaps between others. And so part of that is saying there's one team that can do all of this stuff. And that needs to sit at that sort of locality level. The second focus, and actually the really important bit, which Sarah's just described, is how do we then get into the place where we're building that natural community team, that everyone recognises there's a registered population and there's one team looking after that registered population, and that team can do all of this stuff. If they need stuff beyond that, then they move into the hospital at home model, and we can provide that greater level of intervention clinically, from a therapy perspective, from a social care perspective. But it is about us saying bluntly, there's the natural team, the natural community team, and then there's the broader team. Part of that is about how we suck into it some of our specialists. We've set some of our clinical divisions a challenge that 60% of long-term condition management needs to be done in that community team. They should be getting their diabetes care within that team. They shouldn't be having to travel to a building on an acute hospital site for something that should and can be delivered in their own home, or certainly much closer to their own home than currently. So it is we're developing that ambition. That ambition is we're generating that ambition amongst clinical teams, some of whom, as you would have seen from those themes, are a little bit jaded, a little bit cynical, some of whom are really up for it. And as I was saying to one of the GPs after a big workshop we did up in the University of South Wales, which I told you people would be quite cynical. It was like no more cynical than you were when we sat together in February and I proposed this type of role. So I think it absolutely is about how we progress that. The other important piece then, and Paul touched on it earlier at board, is it's about us getting our house in order in terms of health, so that we've then got a coherent and consistent model that can then integrate with local authorities. Because at the moment, we it's all different. And so a big part of this is bringing us together, and so that we've got a coherent approach, so that we can then integrate properly with local authority services. This is absolutely a programme of work that is going to take a period of time. I think we've made some really positive steps. The enthusiasm is really palpable with the team. There's real engagement, both from the GPs, but also from within our own teams. And it is now about being clear on that programme of work for the next 12, 18 months about how we make this ambition into a clearer delivery plan, and ensure the delivery of that plan going forward.
Thanks, Catherine. Thanks to Sarah. Questions to Patty and then to Kath. Thank you.
Yeah, I just want to say well done for getting the groups of GPs and investors working together in this way, because I know from personal experience this is not easy. The two things I want to just ask really. It didn't say at the beginning of the slide why this group was formed. I know when you work in the health service, you know that all the different tangents of it, but if it could just say at the beginning, this was formed to, and something like that. And I know it talks about articulating the ambition, but that's after, that's the first bit of work. And the other thing I wanted to talk about was the baseline for investment. And it's really difficult, isn't it, to move money from secondary care into primary care? And I'm sure that the GP, talk about teaching granny to suck eggs, I know that. But do the GPs know how difficult that is? And it requires a level of investment before actually that happens. And are they prepared for that? Because what we need to be careful of is not raising expectations as a whole.
I'll go. So Sally and I have been having this. So I think so this isn't. We haven't got shed loads of cash, have we? Sitting in a cupboard, waiting to be distributed to worthy causes. What we are clear about though, this is we as we have this conversation frequently with a load of our services, is we currently spend £1.6 billion. And how we spend that money is it comes to choices, but it is about but it's not always about cash. So I think what we're really clear about here, some of this is not going to be about new money. This is going to be about resource transference. So this is, I will be expecting a number of our physicians to be job planned to be doing that work in the community. It might well be we have a consultant retirement in specialty A. We don't replace that consultant because actually we've moved the service out, and it might be we choose to invest in 2 new specialist nurses to enable that. Part of what we're trying to do at the moment is some really and we're trying to encourage the GPs to be open book on this as well. So Sarah's already shared. This is what she's got. This is how it's all committed. This is what it buys. Part of the conversation is if that bit's buying that and it's the wrong stuff, how do we change it? A load of this, being candid, is being driven by Welsh Government initiatives that have come out with a bit of cash and you need to deliver. And so there's a conversation about how do we, part of the conversation we've had with the team and the GPs is we'll help manage that dynamic, but you've got to come up with a plan that will deliver the outcomes, and we've got to be far more focused on outcomes. But we are being really clear. This isn't about saying there's a whole load of new money to invest. This is partially about, in the main, is about how do we use the resource we've got better to deliver. If there's a compelling case of A or B, then clearly we'll need to consider that. But that needs to be part of our total INTP process. And needs to be assessed in the understanding of everything else.
Sally?
So I think there's a bit here about what we define. So we did a definitional piece a couple of years ago, which said this is what community is. So I suspect if we reran that, it would look like we're spending quite a lot more in community because we're moving things that are into community hospital wards. But is that really what we mean about community services? If you think about this morning, I'm sure everybody would prefer not to think about this morning going through the AGM figures, but I just did a quick tot up. on terms of primary healthcare services, that shifted by 10% or just over 10% last year and increased, mostly driven by the contractual position. Whereas if we look at hospital and community, but largely hospital, it's increased by 21%. That's because of the pay awards and the settlements. So things will move in a different way. So I think I prefer Gethin's approach of let's look at what we're moving rather than sort of ascribing a percentage that we want to get to. Is what services are we moving and what heads are we moving?
Yeah, and that's, and I think that's quite a big cultural shift, isn't it? For an organisation that historically, as in globally across the NHS, has been used to doing more and more things on bigger and bigger hospital sites. And what we've described here, I'll bring Catherine in a moment. I think if they did the work that Paul has chaired, the work that Sarah's been leading, the work that Gethin's been doing around the enhanced community care model, around the hospital at home programme, recruiting healthcare assistants to help people out of hospital package of care. I think what I would like to try and do, and we did commit to this some months ago, and I think I think it's because there's probably lots of other moving parts that are being looked at the same time. I'd like us to try and capture some, at least the ambition at a fairly high level, into a document that says that our out of hospital, however we want to describe it, services, this is the ambition that we have around delivering our services that are away from our principal hospital sites, and incorporate into that the work around those, and getting the conversation we've had around all those different teams that are littered throughout CTM doing lots of really important work, but that are not connected. There's a huge disjoint there. But what that starts to look like in terms of community-based resource, how that's arranged, how it's supported. All of these things will fit together in that bigger piece, that bigger jigsaw. But I think we need to start being able to describe it, and that's the challenge, I think, for us.
We have and Claire might want to come in on this as well. But some of the work that we've been doing with the NAPT is to help us describe that piece. Hasn't been signed off yet, so it's being signed off hopefully in the September. The plan is for it to go to the September primary care transformation group, so we can bring it to board in September as well, because I think that then will answer some of that. But the other bit that's really important is we can't consider this in isolation. So this as I'm sure Claire will go, is part of the whole of CTM 2030, and I'll hand over to Claire at that point.
Well, I can be Claire next, and then we'll cast a question.
So my point was firstly to say thank you, because it's such fantastic work and it is exactly what we should be focusing on, and to just sound that note of caution around creating a vision and principles. We have a vision. It's building healthier communities. It works for every piece of work that we are doing. It is our strategy. And if Gethin was describing an anxiety about connecting European and UK plug sockets, I've got the same, but at the next level up. And so what we must do is make sure that we keep coming back to, and that we have those golden threads running through. So I'm really keen just to make sure that we are seeing this in the context of the overall, the level of complexity of all the things that we're trying to do at once needs to be met with a simplicity and clarity of thinking, which I think might require us to go slow to go fast, if that makes sense for a period.
Yeah, thank you, Claire. Catherine.
Yeah, I just want to say massive thank you to Gethin, Sarah and teams, for bringing this to us. It's so fantastic to have primary care featured on the board and to see all the sort of massive progress that's been made. So really, really pleased to see this. I think my question was around how we're feeding in some of our population health data into this programme and into the redesign of our services, particularly because we know we've got issues around equity, health inclusion. Do you know what I mean? It's like, so I'd be really interested, we've talked a bit about our vision and our ambition, but how are we actually using some of the data we've got to actually really help us, particularly on some of those vulnerable groups around the health inclusion side of things as well, I think would be really important. And the other thing is, as I would say as well, on primary health and mental health as well, I see that you've got a workshop with the community mental health teams, but I would be really keen to see, how mental health is really going to be an integrated part of this programme as well. So we don't lose out on that, because quite often there's such an emphasis on physical health. Mental health doesn't get featured as strongly, which is why I'm trying to emphasise that as well. So yeah.
Yeah, so Gavin, really a helpful question. So one of the things that we need in order to bring that simplicity and clarity is a single version of the truth in terms of that. I would describe it as a doomsday scenario, to do nothing. I mean, the case for change essentially, and also the population health stratified data that helps inform that case for change. So I'm really keen that we have one view of that and that we use it across multiple pieces of work. It becomes our single version of the truth. I suppose the other point, which I would probably make, is that the GPs won't let us forget that anyway, because they know it and feel it every day, don't they? So they'll see it.
I'm just going to say that, especially with mental health, they won't let us forget that. If I may come in on your point around health needs assessment, we're really fortunate. Philip has identified members of the public health team to actually work with us and work closely with us. We have a regular monthly meeting with them, so that health needs assessment is fed into all that we need to do. That does need some maturity and maturing to go with it, but they will be essential to that they provide the bedrock for shaping these services, aren't they? We have to use the health needs assessment to inform where the resources will go. In the past, we haven't done that. We provided equitable resource to all of our areas. Huge learning from that, and we need to apply it in a different way now.
Right, and it'd be great to see that coming through in future presentations, just to be explicit about it. So I know we're doing it, but it's just being explicit, particularly when I think Welsh Government and others will be looking at what we're doing as well, because we're doing fantastically well, aren't we? In this transformation.
Sorry, just to come back. I mean, as Sarah said, we have got a population health management approach within CTM. It is quite important to differentiate what we mean by population health management, inclusion health groups, and where the overlaps and where the offset of an overlap is, or the lacuna, I think is the term. We're bringing a paper to the SDC, where we can discuss the work around equity and inclusion health. In terms of the mental health work, we're in the process of finalising the mental health needs assessment that will feed in. I mean, that will help inform that work. So
great, thank you.
Thanks. So, Hayley on this, absolutely.
Yeah, it was just to say that this is a massive piece of work, isn't it, that we've been talking about quite a lot. And pleased to see that we've had that listening exercise come through. And I suppose it's just a plea really for really kind of getting that theme 4 through with that co-production and meaningful engagement, because we know that this is going to be our workforce that is going to be delivering our vision. If we don't bring them with us, we're going to meet barriers further along the line. And I think that's playing out a little bit with our kind of hospital home consultation at the moment. So definitely co-production with all our stakeholders, community, patients, GPs, workforce, everybody, and down to that kind of local level, rather than someone that kind of thinks they know exactly what's going on the ground. I think that's that voice coming through.
And just coming back on that, I mean, in terms of getting highlighted the fact that primary care is bigger than GPs. And for example, 102 out of the 109 pharmacies are now delivering level 3 smoking cessation services. So rather than phoning up, you can actually walk into your local chemist and speak to a human, and that's really positive.
Yeah. Thanks. So we'll return to this to the board on the 25th of September with a document, whether you call it a plan or a strategy or program, but it will then set out that vision, that ambition about where we expect to be over a period of time. I think from that, what we will need to, I know Sarah and the team have been looking at this, but going forward, whilst we have our own requirements around what we report back to Welsh Government in terms of all the secondary care metrics, we will need also to agree as a board what it is that we want to focus on, that explains to us whether we're delivering against that plan going forward. I think that's a really important piece of work.
And absolutely, Chair, and that ambition includes a set of high-level outcome metrics that this is the whole principle of what we're trying to change. So that will be in the document section.
Fantastic. Thank you very much indeed. Okay, sticking with primary care, we are going to have an update from Gethin and Sarah in respect of the dental services changes that we are facing, particularly on the national contract. Well, potentially facing if government decides to enforce the contract.
So just in terms of introduction, if I may, so you'll be aware that Welsh Government have consulted or have gone out to consultation on a new contract for general dental services. There are a significant range of changes being proposed in that contract, many of which are probably positive. There are some that clearly are create a level of risk. What Sarah will take you through is sort of the range of those key proposed changes. We have replied as a health board in terms of the consultation on that contract, and Sarah will sort of draw out those that we either supported, partially supported, or those that we disagreed with. The purpose of bringing this for board's attention is that it has created a level of anxiety in our general dental contractors, and in some health boards there is already a level of contract handback on the back of this. So I think we wanted to bring it to your awareness. Sarah hasn't included in the slides a position on our intel, but we'll update verbally the sort of where we think we are in terms of the intelligence with our contractors, but recognizing the significant challenge that is access to NHS dentistry. I think it's really important the board has cited on those proposed changes and the potential risks associated with it.
Thanks, Sarah.
Thanks. And the one thing I'd start off by saying is, we've got a number of contracts for all of the independent contractor professions. The dental contract is one of the most complex. It is complex for the dentists to deliver against, and it is also complex for us as a health board to not only implement but also to monitor. So the key changes that I will go through today is around, the first introduction is around segmentation of the contract. So Welsh Government have tried to make the contract as explicit as it can in order to enable the dentist to focus on certain areas. So the focus of attention in the first slide deck you will see is around the focus on providing those care packages, and it's 70% of the contract will be focused on that. The key issue for us is those which patients are going to be prioritised, and you'll see the 10% figure there for urgent treatment and the 10% for those for new patient assessments. So that's the key drivers that the Welsh Government have used for the basis of this contract. I'm not going to dwell on it anymore, but because they've got complexities within them within this just the segmentation. But the other area then of recommendation is they want to redefine urgent care for dental practices, and they've introduced a set of specific standards around access. That includes an introduction of the global oral health assessment, an onward referral. It provides detail of the relief from pain and prevention of deterioration. I'm not going to go into all of the detail, but it provides that definition of urgent care. So and the other important aspect of it is recommending that if a patient has urgent dental care, they should access a dental access portal. It's a national dental access portal that they need to access in order to register themselves that they are in need of urgent dental care. That list is then provided to us, and we as a health board have a responsibility to allocate that patient to a place and to a dentist. Or it could be to our dental teaching unit or our community dental services. It's likely to be either a GP practice because we commission urgent dental sessions, or it is our dental teaching unit where the undergraduates get exposure and the experience of treating patients with real need. We've supported that request. It does provide that definition. So the third item, and I have to apologise, the numbering's out. We go from 3 to 3 and it's 3 to 4. So the other one is then the recommendation. There's an introduction of a national policy for the management of patients for regularly DNA appointments. So we've supported that. There's a high number of DNAs within our dentists, so it means that patients who really do need to be seen can't be seen. It's wasted time for the dentist. So it means then that we can ensure that dentists are really utilising their consultations. So again, that is supported. In respect of free repair and replacement of dental appliances, at the moment that varies whether a dentist would offer it free, a replacement, or whether they would charge. So the recommendation is that contractor must replace or repair an appliance, so that's dentures, likely, within a 12-month period if they've been seen under an urgent treatment plan. But if they are under a normal treatment care plan within a dentist, within a period of 24 months, the dentist again has an obligation to provide that replacement free of charge. Again, we've supported. It's a fair thing to do for our patients. So moving on. In respect of then at end of year reconciliation, so this is a very complex process for us as a health board. We monitor our contracts on a regular basis. There is a mid-year review that takes place by the primary care team. The recommendation is that is shortened for that process. It usually takes 3 to 4 months because you're back and forth with a dentist, they're providing evidence. They're recommending it shortened to 62 days for the dental practices to actually confirm their position. So we've said, yes, we would support that. However, what we're not supporting is that we would be given just 28 days to conclude those discussions and to conclude the contract variation process with our dentists. We've explained that actually our governance processes within the health board don't allow 28 days. From a financial perspective, we need to get sign-off. That generally takes 28 days in itself, let alone then going through our normal governance processes. And for the document, the contract variations document, to be signed by both parties. So that's a partly supported recommendation. I'm going to go through 6, is shared parental leave. So that is supported. So the only contractor, independent contractor, that's the only area or only profession that does not have shared parental leave included. Okay. So we've supported that.
Yeah.
In respect of
It's probably worth, Sarah, just pulling out the ones where we think creates the biggest risk and where we're.
Okay, the biggest risk.
It's useful to see which bits have been endorsed and supported, but if we could deal with those bits, that'd be great. Yeah, lovely.
So the variation notices, again, that's just partially agreed. There's an introduction of 6 months. However, if we want to manage underperformance, we need that to be done immediately. Next one, seniority payments, and then the high need patients. So the recommendation is that patients with high needs who have got 10 interventions should be seen on a separate pathway, and the recommendation is routed through our community dental services. Now, our community dental services see children and they see vulnerable adults, so patients with learning disabilities. We are not supportive of those patients being routed. If you look at if you look at the complexity of lots of our patients, they have lots of dental caries, they have lots of complex needs. It sits alongside deprivation. We will have a huge amount of patients going into our CDA, and it will overwhelm the service, jeopardising access for our children and our vulnerable patients. That's not supported. What also is not supported, and this is the key one, is patient flow. So the recommendation is that when a patient needs to be seen, they might be seen for checkup or might be seen for an urgent. They will come through the system, they'll access the dental access portal, they will go through for treatment. If they need a follow-up, But if they need continuing care, they will have to access the dental portal once again. The allocation of the appointment for that patient may not be the same practice that they received their original dental care. So there's a misnomer. A lot of people think that patients are registered in dental practice. They're not. That ceased a long, long time ago. So this is a key area that we are not supporting. It will mean you will have a loss of continuity of care for our patients, and there will be a lot of discontent with our patients. So next slide, please, Emma. And then patient income charge. This is one for us as a health board we're not supporting. Patients pay a contribution for their dental care. That contribution comes into the health board as an income. And at the moment, the income target that's set by Welsh Government is a historic one, is too high. We will never achieve that income target, which means we're not getting the appropriate level of funding to reinvest into our access.
So just to put that in context, for this year, we think there's a 2 million shortfall on income for what we need to provide in terms of dental capacity for CTM. So that's on a 40 million pound budget. So it is a significant proportion.
Yeah. And the risk to us that Gethin has mentioned is around the discontent from a lot of our dental practitioners. There's been a lot of changes to our dental contract over the last 5 years. Dentists are very fed up with the dental contract. There's a lack of clarity. There's a change that's being made on a year-on-year basis. This does seem to address that because it's making a permanent change and offer for dentists. However, there is a risk. Now, if you look at the percentage hands, the percentage hands back of contracts that we've had within CTM is quite low compared to other health boards. So we've had 2 confidential contracts that have been 3 that were handed back last year. One, and the impact can vary on the size of the contract. However, when we've spoken to our dental contractors, we estimate that they will be on a par with the same level of contract hand back. The risk is with this, either they will hand back their contract and they will decide to deliver private care, which is not good for our population.
Okay. Thank you. That was really helpful. And it's a very complex set of negotiations. But obviously, this is still in a state of flux, isn't it?
It is in a state of flux, and I think it is worth noting that we had people from the health board involved in part of the negotiation team, and the contract that went out is different to what there were additional items put into the contract for negotiation that were put in by Welsh Government after some of those negotiations. So I think there is a challenge there for us. The reality is the capacity of dentistry in CTM isn't as good as it needs to be, and anything that reduces that increases the likelihood of handing contracts back is a problem. Thank you.
Any questions to? So yes, Kathy. Thank you.
Yeah, I just want to ask about the dental access portal. Does that already exist?
It does already exist. It has been promoted on our share page, and it's been advertised nationally as well. So, but we've had a dental portal for a dental list for a long time within CTM. It sits within our urgent care service, which is the navigation hub. When a patient phones in for an urgent appointment, there's a list, and then our team allocates them out to a practice.
Okay, so it's
a variation of.
So it's a CTM system.
No, it's a national system. We used to have a CTM system, so it works well for us. But this is now a national system that went live in June.
Yeah. Thank you, Kathy. Okay, thank you very much indeed for the update report. Much appreciated. Move on to 614, the IMTP Q1 review, and I'll hand it to Claire. Thank you.
Yeah, thank you, Chair. So
You need to unlock your iPhone first.
Not mine.
So board has asked to note this report. I think we've already discussed the number and range and scope of performance metrics this morning. So we've already discussed the performance metrics in the IMTP in the IPR. We've already discussed the revenue and capital position in this IMTP report in the finance section. The ministerial priorities that are listed out there around timely access, population health, community access, mental health and women's health hubs. The data, some of the data is there, not all of it is yet available. I think there's, and then there are a series of enabling actions and reports on all of those. You'll see there's an immense amount of detail in here, and one of the things that I think we need to work on is how we respond to Welsh Government and provide assurance to the board without requiring our staff to produce copious repetitive reports.
Thank you, Claire. And I appreciate the amount of information in here as well, the accompanying documents which supported the paper. Any questions to Claire today on the update on the IMTP? And also one of the critical factors will be, as we get through the year, attempting to realise some of the ambition we set out around, the digital and data piece, the allocation of resources we want to find towards that, expanding our healthy weight services, those sorts of things. I know that a lot of this is conditional on what we can do around, delivering our plan, but obviously, the Brucey bonus and all of that delivering of our plan is securing, the investment in those, much needed, areas of transformation. But no, thank you for the update. If there are no questions to Claire, we'll just note the report. Move on to item 7, our population and working with others. Item 7.1 is the regional partnership agreement for services and support for older people and people living with frailty and their carers. Delighted that both Claire and of course Matt has done, as I've said this time and time again, I will repeat it again today, immense work in leading this significant amount of partnership working between health and local government to pull together a high level of ambition to be more joined up in how we plan and deliver those services that people experience and for to us as statutory parties deliver. And quite frankly, what Matt has been doing here in CTM, in my view, ought to be replicated everywhere else in Wales, because the levers and the opportunities are there. And it is amazing to know that through Matt's leadership that we've been able to secure such incredible agreement and progress in getting to where we are today on this. And the future has to be in that integrated service model, bringing together what we do, but also what we do with others. And Matt's been fantastic, so I really appreciate everything you've done. So Claire, am I handing it to you first, or is it to Matt? Or
Really to say what you've said essentially, and that it links to the work, of course, that Gethin and Sarah.
Yeah, absolutely. Yeah, thanks, Claire. Matt, thank you, over to you.
Thank you, Chair, for the introduction. I think it does fit well, doesn't it, with conversations and presentations that you just had. The paper that you have, of course, builds on previous discussions and decisions at board, notably the regional memorandum of understanding, which is agreed to Paul's Chief Executive's report last November. That was a precursor to this agreement. It directed the work that's been done on the RPA, and then CAT's Strategic Development Committee took the paper earlier this month and endorsed it for approval by the board. The context, as we've already heard, is about continuity and coordination of care being absolutely essential for this increasing group of older people living with frailty in our population. We need to create an more effective, more integrated response. And the trouble is, a lot of the system drivers, planning, performance, funding, inspection, regulation, they tend to drive us in the opposite direction, don't they, from that spirit of joint working that we need across health and social care, and wider indeed into wellbeing services with third sector partners. So that's the reason why we've developed a stronger binding framework across statutory partners. I think to some extent, it prepares the way for that plug and socket plan. That I guess in the analogy that he was using earlier, is it's not the plan in of itself, but it gives us some important tools now to develop that. So specifically for the board, then, what the regional partnership agreement does, what we would do here to endorse it, would be to connect the board and the 3 local authorities to a single target model of integrated teams on a local footprint. In outline, detail to follow was described through Sarah and Gethin's presentation, and the aspects of that, the face local authorities obviously to be co-produced with them, but the sense of once it comes out from Galway approach in the context and compared to that high complexity that we know we have already. Secondly, the creation of a shared accountability framework. That's important. We rely on each other's services so much, don't we? Sometimes we're commissioning the same provider, so to be able to do that together in future is key. The agreement will enable us to maintain and create those matrix posts that we need for integrated working, to pool resources. At the moment, we feel that there's sufficient maturity in our system to be able to do that. And finally, I think it's a flexible framework. You know, the heads of terms is meant to have a degree of shelf life. We can attach new service schedules to that as and when we've done the work then behind the scenes to get that consistent, set the pathways across the region. So I think to be clear and for the record, this doesn't change the statutory duties of the health board, rather it enables organisations to work more flexibly across organisational boundaries that currently exist. As you've seen from the paper, the 3 local authorities have taken this paper in turn. It's been through some quite significant scrutiny, consideration, and indeed the 3 cabinets themselves. Nothing substantive has arisen through that process. There are a small number of recommendations that authorities have made to improve the document. Sometimes it's about readability. There's a query on insurance and liability, but I don't think anything here that would substantively change the document. So my proposal would be to sweep that up along. Then feedback might be more significant than that, of course, from board today, but then to provide a final copy, a clean copy back to organisations ahead of then the intended start of the agreement, which would be the 1st of October. So just then in referring you to the recommendations on the section 5 of the paper, there's a small error here that refers you to paragraphs 2.1 and 2.8, and I think rather than that, it's the wider context in the paper, including the programme of work that supports all this, but most importantly, the secure agreement and the regional partnership agreement, which is an annex A to the paper. Chair.
Thank you, Matt. Like I said, a huge amount of work has gone into delivering this, a massive amount of preparation work, building confidence, bringing people together, thinking through what could be achieved collectively between us and the 3 local authorities. And the 3 local authorities have now signed this off at their cabinets in their July cabinet meetings, which again there's a great show of confidence on that partnership working programme. Clearly, I think it's already shared with the rest of Wales. I don't know if Welsh Government have been cited on this particular document yet. I know it's now a public document.
Indeed.
So I think we should be encouraging them to share this with others to see if these sorts of things can be replicated, because as I said, the levers are there to deliver on this integrated agenda. And I think it potentially very exciting in terms of what it might lead to. Any questions from Patrick?
Yeah, just a quick one. I mean, this has got to be the way forward, hasn't it? There is no other choice for health and social care going forward. But we need to be able to get away from having to account for the bits that we spend in health and having to account separately for the bits that are spent in local authority. And that's Welsh Government. That's not within our gift. I know we've got to be able to do that. So it genuinely is a pot of money that is spent for the benefit of the patient, whether it's health or social care. As soon as we've got to start working out how much health is spent, and we lose the integrity of it. I don't know how that can happen, other than Welsh Government changing the rules. But that's what's got to. But totally supportive.
I just agree. I mean, the structures that we have, they go back to the middle part of the last century, don't they? Let alone being fit for the purpose of now in the middle part of this century. Welsh Government are edging towards this. They would say that they have developed a blueprint for an integrated community care system, has many of the features, but I think the stronger binding legal agreement that we would have marks us out uniquely in Wales across the scope and breadth of what's described here in the community pathway. So a bit of a promotion job potentially to do nationally, I think, with this now that we're on ourselves. Thank you, Matt. Hey.
So it's just a little bit of clarification, really. Reading through, it was saying that the only service that's covered in this is the payment of bridge end services. It's just sort of what I call the bridge end stuff. And it's like, how come it doesn't spread to the north of Reablement and that?
Yeah.
I don't quite understand.
Consistent with Sarah Bradley's description, I think, of that map of the way services are arranged currently. We've inherited a model from Bridgend that came over with health board reconfiguration, and then we have a pattern in Rotherkin and Taff and Merthyr Tydfil. So the programme of work now stretching out to 2027 is to do this work on the care model that cuts across the acute clinical plan and other areas as well. And then as we have that
to reset local services based on that consistent model. There's an enormous amount of co-production that needs to do with staff through this, because I think, organograms and, strategic plans are all well and good, aren't they? But it's the people at the front line that understand where they're getting tripped up in terms of supporting population, because we can't access this team over here, or we don't understand what they do.
And those are the people that need to be included.
So really taking that out on another day where we are with some of the milestones of the programme, we just need to get our things in a row. There's that staff consultation with the hospital home service now, which perhaps isn't quite the moment to go out and then talk about a further layer of engagement between local authorities, but that's kind of critical and central to this. So we need to do the work, and that anticipated milestone in spring 27, where we would have that consistent model, and I think locality based as well. I think we would have a Bridgend and RCT and Merthyr Tydfil approach to that, at least in terms of this agreement. But yeah, then we would have that equivalence across the as well.
Helen.
Thanks so much, John. But echo your comments about the work done. It's great work, Matt. So thank you. I just wondered, in terms of this board and these arrangements, how will we see this in the future? In terms of accountability and coming back to the board? How often do we expect to see something come to us to tell us how this is working?
Yeah, I mean, Matt, you may have some thoughts as to what would work practically. I mean, obviously, I wouldn't expect an update, in every single board, but whether we did that twice a year, and I don't know what would suit into. Likewise, I don't want people to have to spend so much time having to do lots of reporting, whereas it's getting on and doing, which is really important.
The reporting is done largely through regional structures, I suppose, on a more consistent basis. The partnership agreement is one of the outputs of the programme. There's a lot else going on beside it to get that full picture, because I think it does sit together. And again, I wouldn't probably want to describe this in isolation from the other change programme to be clear about this morning as well. So we need to find a way of doing that. And Blair's absolutely passionate about bringing this together. So it's one coherent program of change rather than things that separately.
I'm not suggesting we have something every time, but
like that. I think the agreement itself as well should be refreshed rather than just left on the shelf. So
it does get picked up in strategic development committee as well, in terms of SDC as well. So we're picking up all the transformation programs in that committee as well. It will come through there as well.
Okay, the regional partnership agreement is before the board for approval. Can I ask the board to approve the agreement?
Yeah.
Thank you very much. And the board just notes the report that accompanies this as well, and the intention to seek approval, obviously, from the other local authorities, as we understand it, has been agreed by the three cabinets. I know there's been a very strong level of political agreement as well, which has been fantastic. And no doubt we will return to this during the course of the year. But it really is great to have got to this particular point. And Matt, again, thanks for everything you've done to lead this, and to continue to lead it. Thank you. Thank you much indeed. Thanks. Appreciate that. Thank you. Okay, moving on to item 8, the consent agenda. If I can ask the board just to approve en bloc those matters listed under 8.1. And if I can just ask you to note those matters listed under 8.2 for noting. No other items of business have been notified today. And in terms of meeting feedback, if colleagues have any comments that would improve the handling of board meetings, please do so within the next 2 weeks. I do encourage feedback. Feedback is encouraged. Even if it's difficult, more than happy for, not now, Dom. I don't encourage you on the day. There are limitations. But within the next 2 weeks, anything that colleagues wish to flag to improve the efficiency and effectiveness of meetings, please do so. There is an in-committee board meeting following this meeting to cover the transforming access to medicines South East Wales online business case, the radiology centralisation of nuclear medicine service provision, a Sputty George Thomas Community Hospital consultation, and the National Outpatient Plan, which is the waiting list initiative and outsourcing. And the next meeting of the board in public will be on the 25th of September. Rydw i'n dod y cyfarfod y bodd iethu y ben a hofyn y diolch y bawb sydd wedi ymuno a ni gwylio cyfarfod heddiw. I now bring the board meeting to a close. I would like to extend my thanks to all those who participated in the meeting or those who observed remotely. Thank you very much. We are done.